How are you all doing? You made it to the end. This is going to be very exciting. I'm going to wake you up. We're going to be we'll be very interactive today. So, okay, so we're going to be talking about stigma. We're talking about drugs, all the fun stuff. No disclosures, but if you want me to do something for you, I'm happy to. Learning objectives. Okay, so I want you all to know rates of substance use disorders in older adults living with HIV. I want you to be familiar with screeners so that you can actually start having discussions around substance use with your patients, and then how we're going to integrate harm reduction and non-stigmatizing language into patient interactions. We'll start with a case. So this is someone, kind of an archetypical case I'll see in a lot of my clinics as well. So this is a man, we'll call him Mr. X. He's a 64-year-old man with HIV, hypertension, and diabetes. He comes to your primary care clinic. Over the past year, you've noticed that despite being on and compliant with medications, his blood pressure is going a little up, and you've noticed his weight coming down. And throughout some of your appointments, he looks jittery, maybe he looks like he's nodding off a little. He doesn't look just right to you. So you start asking him like about life and everything that's going on with him, and he says, you know, things haven't been going great. I've been struggling to make friends since my partner passed away. He's been going back to bars. Maybe he's drinking too much, but nothing else, you know, not usually. And he thinks he'll be okay. He doesn't want to talk about it. So keep this case in mind. We're going to go through a bunch of like facts and fun stuff, and then we'll come back to him at the end to figure out kind of like what your next steps would be. So, spoiler alert, people are still using drugs, and it's not going down, really. I think what we're seeing in national data is consistently slight increases. During COVID, we saw some decreases in substance use, but things are kind of like edging back to where they were a few years ago. So in the past years, and this is kind of like large data samples from California, we're seeing, obviously the most widely used substance is cannabis, and though it's, it's federally illegal still, though we in California have legalized it. But we are still seeing kind of like stimulant use, we're seeing opioid use, and we're seeing nicotine use. A lot of substances that people are using. We're seeing in California, looking kind of broadly in the state, there's about 8 to 10% of the population that has a substance use disorder. The majority of that is going to be people who are drinking. After that, kind of like we collectively look at illicit drugs, which are going to include cannabis, opioids, stimulants, and all of those other kind of like hallucinogens, but not to the extent. This is important to know because we're in our worst overdose crisis ever, and we're still seeing kind of nationally the worst overdose data we have. It's kind of leveling out, which is kind of nice. Like this is the first year in LA County that our overdose data went from like 3,023 last year. We're estimating it's going to be like 3,010. So maybe it's like evened out, but that's still 3,000 people a year dying from an overdose. When we think about who's dying from an overdose, obviously, we're very concerned about like the 16, 17-year-old kids who are dying, the people who are in their 30s. But when we look at the graphs, there are also a bunch of people in the older age population that are dying. And when we think about like the older age dying, we're losing a lot of wisdom, right? When Megan had that slide about like what 82 makes you think of, like I thought of wisdom because it's like, they've lived a life. Like they have so much to impart on our younger generations. And if they're dying from an overdose, from something that's very preventable, that again is going to be important when we have like open and honest conversations with our patients, we're really kind of like doing such a disservice to our younger populations. So when we look at like overdose rates, and again, this is kind of like consistent with what we're seeing now, we're still seeing, huge increases of overdoses because of fentanyl. What's kind of nice is that opioid prescribing deaths have actually reduced. So this means that as providers, we're doing better at prescribing opioids. We know that we got us into this mess of, the early 2000s and pain being the fifth vital sign and overprescribing. We've now kind of like curtailed a lot of that, which is wonderful. But now kind of like with the combination of illicit fentanyl into so many of our street drugs, we're seeing this massive increase in death. We're also seeing increases in amphetamine, and especially kind of on the West Coast, we're seeing much more amphetamine-related EDs and ED visits and deaths compared to like the East Coast. When we think about older adults and substance use, generally kind of what's protective about age is the risk of developing a substance use disorder decreases beyond your 20s. So like, for example, if someone starts drinking at the age of 14, they're 5 times more likely to develop a substance use disorder than if they were to drink at 21. So we know the older someone gets, the less likely they're going to develop a substance use disorder. This is also kind of tricky, just like we saw kind of with screeners around sexual activities. We're not really great at screening patients for substance use, and we don't necessarily do it in the best way, right? When I come and ask you, I'm like, what drugs are you using? You're less likely to be like, oh, this is a really non-judgmental conversation. So people are most likely going to be like, nah, I'm not using anything, thanks, don't worry about the needle hanging out of my arm. And then when we think about like adults who have other medical comorbidities, so with older HIV positive adults, for example, if they have alcohol use disorder, they're at a much higher rate of developing another substance use disorder, as high as, close to 78 to 80%, or having a mood disorder. And we know that things that increase people's risks of using substances could include mood or other kind of like comorbid psychiatric conditions. Specifically with substance use in HIV positive older adults, so again, kind of like what we see nationally and even within California, alcohol is going to be the most used substance, but substance use prevalence rates excluding alcohol increase with patients over 50 as well. What we're going to likely see is because the aging population of what we're seeing now, kind of like the baby boomers, they kind of had an adolescence where they didn't necessarily have fentanyl. And so their use of like illicit substances was much looser than what we're trying to like teach our youth now. So we expect that older adults are still going to be experimenting. And we have things like psilocybin, we have ketamine, we have MDMA, which unfortunately the FDA did not approve yesterday for PTSD treatment, which is very sad. But we have all of these substances that are also very easily accessible. And so we have to start thinking broadly about how people are taking care of themselves and how we're having conversations about wellness that involve substance use curiosity. I'm going to name just kind of like a few big studies so we can see kind of like what's actually been examined with the HIV older populations. So this was one of the largest studies we had from the Veterans Association, and they looked at close to like 6,300 patients over the age of 50. And they found that patients with HIV were commonly more reporting problematic drug use compared to people who were demographically and not infected with HIV or didn't have an HIV diagnosis. So the substances that they were more likely to use, again, in this like VA study, so we think of like mostly men, mostly people who've been involved in some sort of veteran military kind of like population. They're smoking a lot more. They're using stimulants and cannabis, and then lower rates of opioids, which is kind of interesting to me because when we think of like pain and we think of like patients who have gone through kind of like the service, they oftentimes have higher rates of opioid prescribing. So this was really interesting to me. When we looked at kind of another study, and this one came out of Australia, I think. So this was a multi-site study looking at older HIV positive patients with depressive symptoms. So again, we're adding on mental health diagnoses and an HIV diagnosis. They were 25% of them had used substances in the last 2 months. Again, stimulants, cannabis, and then other drugs, including opioids and benzos, almost half of them. So again, half of them, those were the substances that half of them were using. And finally, looking at methamphetamine use among men. So this was another study comparing HIV positive and HIV negative men. They were trying to see who was more likely to use a stimulant. So they found that people in their 40s who were single, who were also HIV positive, who used other drugs in the past 12 months were more likely to be using methamphetamine. And we know this is important because we know methamphetamine, especially on the West Coast, is cut with a lot of fentanyl. So again, you're going to be like, oh, if you are using meth, how are we going to make sure we're introducing harm reduction into your life so that you can stay alive in case anything's cut with fent that you're using? Okay, so now we know older adults are using substances. We know that their rates aren't necessarily decreasing, so they still need all of the interventions and all of that open, honest conversation that we give to other members of the population, especially people with HIV. Or it's important to like have these conversations because we know that substance use accelerates the progression of HIV. So it can do things like increase their viral load, increase the likelihood of comorbidities even when they're adherent to their medication. We also know that being on substances can cause a decrease in medication adherence. We know that when substances enter the brain, we know HIV can enter the brain. We know that as the substances kind of weaken that blood-brain barrier, it allows for other infections to possibly enter the brain or impact the central nervous system. It can also increase the release of things like neurotoxins. It's pro-inflammatory, and it can also damage other parts of the brain that we need people's brains to be healthy to live quality lives. When we think about risk factors for substance use, I'm categorizing them in like 3 big things that we constantly want to look at. So I think the biggest one for me is kind of like psychological and mental health. So when we think about this, this is a conference on stigma. So we think really kind of like about how stigma, stress, all of that impacts someone's mental health. The moments where we're feeling kind of like depressed, lonely, isolated, all of those can be associated with subsequent substance use and then risky behavior. So when I have patients come in and they're just like, God, I'm feeling so shitty right now. I need to feel better. I need to do something that like shifts my mood. The quickest way I can do that is like a substance or a risky behavior that like shoots up our dopamine. And so if we understand kind of like where they are psychologically, we can talk about like ways to help them feel less isolated, feel less stigmatized. Then we think about sociodemographic and healthcare disparities. We know a lot of our patients who are older already have kind of like limited access to care. Most of the patients I treat are kind of like struggling with housing and on Skid Row, and they're like, I can't go to a doctor. And these are the patients who are also doing things like sharing needles or having unprotected sex or not getting tested. So we know that those things are also going to impact kind of like their risk for using substances. And then finally, kind of like comorbidities and quality of life. So again, if they're isolated, if they're struggling with other health problems, anything that can like shift my mood or shift the way I'm feeling is going to be something really, really attractive to me. Okay, how many of you all use screeners when you talk to your patients when you think about substance use? Yeah, you do. What screener do you use? Okay. So screening to brief intervention. Anyone else use anything else? DAST. Okay, I like the DAST. Good. Okay, cool. Those are like the 2 that I didn't put on here. So yeah, okay. I'll introduce some more. Okay, so screening I think is really important. We have patients fill out a bunch of paperwork, and it's always fascinating what they do and what they don't fill out. But with like substance use screeners, I find it really interesting because when you ask someone, their automatic answer is to kind of like either underreport or be a little defensive in their reporting. When I give like paper to someone, they tend to be less defensive. So I think as a correlate, I work with a lot of like juvenile populations also, and I'll give them stuff. And when I ask them, I'm like, how much are you drinking? They're like, I don't drink at all. But then when they're filling it out for me, they're much more honest. So I like the idea of a screener because it gives them both autonomy and privacy in doing it. And then you can kind of like prepare yourself for then how you're going to have that conversation. So the 2 kind of like biggest ones that are also just easy to get, the NIDA quick screen and then the TAPS. So those are the 2 that I'm going to kind of just talk about today. I think the really, really important thing about screening is that it doesn't necessarily involve a urine drug screen. How many of you all kind of urine drug screen your patients? Like randomly? Yeah. Do you randomly drug screen them? Okay, good. Okay. Yay, okay, good. So again, drug screens when it's appropriate, when the patient consents. And then if screeners come back positive, it doesn't necessarily mean someone has a substance use disorder. The way that I start thinking about it, and I'll go over this again, is like, this is an opening to a conversation about how they're taking care of themselves and what their wellness routine is kind of like. So the NIDA quick screen, you can do it online, you can print it out. Online is really easy because they'll essentially, like if you have a tablet, you can give it to them. They'll fill out these dots basically. They'll ask like how often you're drinking using tobacco, prescription or illegal drugs. And then depending on their answers, they'll ask for more detailed information. So it kind of gives you a really good spread of what they're using. And then we have the TAPS, which is tobacco, alcohol, prescription medications, and other substances. So the first component, kind of like a mini screener, basically just asks what you're using. And if you screen positive on any of that, then they'll ask for more details and kind of like stratify people into a risk category for you. When we use screeners, and I think this is kind of like really, really important, the way that I've learned to kind of like ask about substances, even when someone like tests positive on a screener, does something that's very concerning. I like to open it with like, how are you taking care of yourself? Like, I think that's a really, I think it's both strategic and it's also very opening because people are like, oh, I don't really know. A lot of times you disarm them in the way that you're like, oh, you're not asking about like my substance use. You're asking about like my relationship with my body, my relationship with my mind, kind of like how everything looks holistically. And when I start that, in my mind, I'm like, I have like a pathway that I'm like, I need to get to substances because you're using meth and you're not, you have no Narcan. But I'm so curious because like, oftentimes you'll see like, I'm really stressed. I don't really have anyone to talk to. I think taking care of myself means that like, I eat a donut when I'm down, or I snort some meth if I'm really tired, or I take a benzo when I'm not sleeping. And so you get this like landscape picture of them. And when I follow up with like, tell me about how you're taking care of themselves, I'll often ask like, how does your room look? Or how does like, describe like a person that's really important to you, just to get like really kind of like concrete anchors in their lives. So you can start like painting a picture, right? Because I think this is so important that we're not just treating what people say on screeners or how they report or what their vitals are, what their labs are, but you're like looking at this like holistically so that you can actually do an intervention that's effective for them. So asking about like how you're dealing with stress, how you're dealing with life, like what do you enjoy? How do you celebrate? Like those are all things that I really like, I like to think about too. When people are like, what do you do after a bad day? They're like, God, I ate a lot of cake. And then another person's like, I'm like, how do you celebrate? They're like, I eat cake. And it's just like interesting how we all kind of like all eat cake, no matter what you do. But like it's interesting to get these points from people because then you really like start to understand them. So I think that's like a way to kind of reframe the conversation around like, what you're doing to yourself is important because I want to make sure that I'm promoting health and I'm getting you to a quality of life that you want. Okay. Oh no. Oh gosh. You've seen all the answers. Okay, don't look. Okay. Okay, stigma. Okay, we've talked about stigma a lot, so you all know what stigma is, which is great. We know that, especially with substance use, it creates barriers. I mean, all of health and mental health and substance use, it creates barriers. Then it causes, people internalize stigma, and then it causes that loss of self-respect, self-efficacy, decreased self-esteem. Specifically with substance use, I think the stigma around substance use, and I think we're still moving towards society truly understanding that, a substance use disorder or addiction is a chronic brain disease and not a moral failing. I still feel like we constantly battle against the like, they have to be ready for treatment. And that bothers me so much because when like someone comes into your office and their blood sugar is like 600 and they're eating like crap and not exercising, you don't tell them, go out and lose weight and eat better and then come back when you're ready for treatment. You're like, no, let's start you on medications. Let's get you to see a dietitian. Let's talk about your exercise routine. You're doing everything at the same time. I think within the substance world, still like some residential treatment centers or some treatment providers will still say they have to be ready for treatment. It's like, well, what does that even mean? Let's give them a medication. Let's give them all of the support they need. Let's overload them on their support so they can access things when and how they want to. I think that's still kind of like moral failing is something that we really struggle with, and I think that impacts people's ability to access services, or at least even say when they need services. We oftentimes criminalize people for using substances. I think we've seen kind of like the kind of like institutionalized racism of who is incarcerated, who isn't. We link that then to kind of the morality clause of people being bad if they're using drugs or good if they're not. I'll talk kind of about language in a minute, but all of those things are kind of like how stigma then like folds into the inability of people to kind of access care if they want. And so like, as we start thinking about this, I want us to start moving towards using language that's more supportive for people who use drugs. The way that I think we've done this well is by actually using having people who use drugs come into our spaces to say, this is the language that I would be comfortable someone using with me. This is how I think, when you say this word, this is what it makes me feel. When you say this word, this is how it helps me understand you a little better. I think it's really important to have these relationships with people who use drugs, build relationships and forge kind of like manage difficult conversations and uncomfortable positions that you may be put in. And then as you're kind of like building this language, remember that the roots of substance use disorder are not kind of like, again, in moral failing or a choice. We know that substance use disorder stems a lot from like genetics and family history. We know adverse childhood experiences, comorbid conditions all increase the likelihood of someone using substances and then developing a substance use disorder. And that we ultimately want to kind of just improve the health and well-being of people in general. So I think keeping those big ideas in mind as you start to develop more supportive language is going to be really important. But we are going to practice that right now. So I think the first one didn't, okay. Okay, so the first one is people oftentimes use things like addict or alcoholic or user or junkie. So instead of using that kind of like those words in that language, what's another way we can refer to someone? Somebody uses substances, perfect. Someone who what? Someone who's dependent, okay, okay. What else?
Self-medication.
Self-medication, okay, perfect. What I think is important about this is moving away from like isolating someone's identity as just being like an addict or an alcoholic is really minimizing their kind of like humanity. And so a person with a substance use disorder, a person struggling with alcohol use disorder means that first and foremost, they are a person. And then they also have a bunch of medical conditions that we wouldn't say like, oh, this diabetic. We would say a person with diabetes. And I think it helps kind of like frame substance use disorder in that medical model that is also recognizing that people have many layers. They can be a father, a mother, a tennis player, a physician, a banker, all of those things that people have worked really hard to be in life isn't then reduced to just them being like an addict. So moving towards kind of like that first person language and moving away from recognizing that the person is not the problem, but the person has a condition. Okay, let's try another one. If we wanted to change habit or abuse, what would you want to change that to? Use? Okay, good, good. What else? Unhealthy relationship. Okay, yeah, go for it. What else?
Life
choices. Okay, good, good, good. Perfect. So instead of like this person has a habit or it's an abuse, you can say they have substance use disorder. You can just say use, right? So instead of like they have a habit, they're continually using a X substance. And then if there's prescription medications concerned, you can say a misuse or used other than prescribed. Right? Yeah, no, the other than prescribed. It's very nice. Because I think, when we think of like a use and a habit, I think it implies that the person is choosing and then they can then choose to stop. And I think we can all recognize that like we all have behaviors that we do that are really difficult to change, whether it's like eating healthier, exercising, balancing like your checkbook. I don't know who has a checkbook, but like you balance your finances. Like all of those things are really, really hard. And we don't like choose to be people who don't eat well or exercise and all of those things, but oftentimes it's a struggle. And so I think recognizing that is really, really important. I think the idea of like a habit undermining the idea that this is a chronic brain condition is also very important. And then abuse is just kind of associated with just a lot of judgment and negative attitudes. Okay, so this is kind of a newer one, but instead of people using opioid substitution, replacement therapy, or even medication-assisted treatment, which we still oftentimes use, but now we're kind of like moving towards new language, what do you think you would all change it to? You're like, that sounds great. And it does, but it could be better. Just treatment. Okay, I like that. So we do like opioid agonist therapy, pharmacotherapy, addiction medication. So this is kind of our new push towards medications for addiction treatment, just for addiction medication. Just like you have high blood pressure medication, just like you have diabetes medication, all of that, instead of it being like medication-assisted treatment, it's just addiction medication. And then we also oftentimes use medication for opioid use disorder. I think the reason that they kind of like shifted away from substitution replacement therapy is in a lot of like 12-step programs when you go to like AA or NA, if you're on like naltrexone, Suboxone, buprenorphine, methadone, they'll say technically you're not truly abstinent because they say you're just replacing one substance for another. In my mind, it's definitely like a personal choice, and I'm like, I would much rather have someone on Suboxone or methadone than like heroin or fentanyl or anything else, right? And so it's about like having them have the autonomy to say, no, this is something I'm doing for my own health and well-being. So that was kind of like a big change. And again, we want to move away from the misconception that medications are a substitute. And then, imply the term MAT really just implies that medication should have a supplemental or temporary effect. And oftentimes people are like, I'm great on methadone. Like, I do not use any substances. I'm not getting arrested. I'm making better life choices. And that's great. So they don't need anything like psychotherapy or anything else to go along with it. Okay, and then finally, this is a big one. Okay, instead of clean and dirty, what could we use? Substance-free. Substance-free, okay. Actively using, okay. What? Relapsing, okay, perfect. So, I like that. So for toxicology test, what I've started doing is expected or unexpected result. Because even when we went from like clean and dirty to like negative and positive, and I was like, oh, your urine drug screen was negative for XYZ, people were still like, well, it sounds weird if you're saying something's negative for something. Like, is that bad? And so we were like, oh, let's just move to kind of expected and unexpected. So if we know that you're currently using substances, I'm expecting your urine drug screen to be positive, or oh gosh, to be to have whatever substance you're using. And if you're not using substances, or you're saying you're not using substances, it's going to be an unexpected result when you have a result that shows or demonstrates a substance. So I think there's ways, again, making people feel like what they're doing is not, they are not bad for the behaviors that they're doing. But I like the idea of actively, using. But we just want to make sure we're doing non-stigmatized terminology and words. Okay, perfect. Oh, okay. So now we're going to move into harm reduction. Yes?
Honestly, too, is that sometimes there's a questioning of the values of NA and AA, because there's even a question of, like, one would be 12 years placed in sobriety, and one is placing 1 year sobriety, and they're sponsored, and there's already a hierarchy.
Right.
Even in that area and group. And honestly, I mean, it can work, but it just fluctuates from one case to another, whether it's going to be a program for the person who's seeking help and seeking sobriety in that sense.
Exactly. A lot of these 12-step programs, I think, are very individualized. So yeah. Okay, so the question was kind of like exploring how in 12-step programs, there's oftentimes already an internal hierarchy between people who have been abstinent for, say, a dozen years versus 1 year. There's already kind of like a dynamic between you and your sponsor around expectations of sobriety. And that may not be great for some people. So some people may have kind of a different idea of what they would like in either a support group or what their idea of sobriety even means. So I think when you talk to people around like what their goals are, I think that's kind of like the core, what's really important. Because maybe my goal is to magically find pure heroin and not use fentanyl. Your goal may be like, I don't want to use opioids at all. And I think that's like the core of like actually learning about your patient and trying to figure out what's going to keep them safe and healthy and getting to all of their goals in life. Which leads into harm reduction. Does anyone know what harm reduction is? Tell me. Yes.
People are going to kind of be exposed to harm in some way inevitably, so there's different strategies to help reduce that.
Perfect. Okay, so people are going to be exposed to harm inevitably, so strategies to reduce harm. That's great. Harm to themselves or others. Perfect. Anything else? Okay, I mean, you kind of hit it on the nail. When I think about harm reduction, I think what's happening is like a lot of people have purely been associating it with substance use. And we kind of telescope back, just like you said, when I think about harm reduction, I think about anything we do to reduce consequences of harm in ourselves or in the community. And so we think about like seat belts. We think about like going to see your doctor. We think about like taking medication for your chronic illness. We think about calling for a rideshare service if you've had too much to drink. Those are all things in harm reduction. It's a condom. It's all of that is in harm reduction. When we think about harm reduction specifically for like substance use, we think about ways to reduce things like the negative effects of substances. So overdose, bloodborne pathogens, anything like that. So it's going to reduce overdose, prevent communicable diseases, and then offer people kind of like what they want. So at its core, it's like, when I think about harm reduction, I think about a way to build relationships with someone to understand what they want and how to help get them there. Cool, okay. Okay, perfect. So we run into a lot of kind of like negative press around harm reduction. People are oftentimes like, oh my God, you're giving someone a needle, or you're giving someone like, safe supply to use substances. It means you're like enabling or you're encouraging use. We know that what harm reduction truly does is provide people safe supply because, huge news, they're going to use substances. People are using substances for a variety of reasons. They may not be ready, willing, or able to reduce or stop their use, but making sure they have like sterile equipment to use is going to be really important both for their health and the health of the community. We know that providing harm reduction services and supplies reduces things like bloodborne diseases, also like kind of like public chaos and needles on the street, for example. And so I think we have to like reframe the idea that harm reduction enables when we have such good data that is actually a way to prevent diseases and kind of like connect people to services. When we think about kind of like why harm reduction is so important, I'm sorry, we have 10 minutes, so I'm going to speed through these a little quickly. When we think about risk factors for overdose, I think it's important because a lot of our patients, now that we know they're using substances, they're going to be at risk factors for overdose and death. And we can't help someone who's dead, so we want to keep them alive. So if they're using alone, you want to make sure they either are using like with friends, or they have a hotline like the Never Use Alone hotline or the Brave app open to have someone call for help or at least administer naloxone. Understanding tolerance. So if they've taken a break for some reason, if they've been like incarcerated or in the hospital for some reason, we know that we need to tell them to start low and go slow because your tolerance levels are going to kind of reset. Drug quality. So we know fentanyl has been kind of like just folded into basically all of the substances that are out there right now. So we know we have to make sure that they know to test for fentanyl and then what to do if they find fentanyl in their substances. Encouraging them to use one substance at a time so they're not packing things over and over again. That can lead to an overdose. And reducing kind of like the riskier ways of use. So maybe they're going from injecting to smoking. And then again, people on the outer ends of the spectrum of age are at higher risks for overdose too. Okay, these are all kind of like harm reduction examples, which all of you know. Fentanyl's in everything, not everything, 70%. So we can assume it's in like the majority of the illicit substances people are getting on the street, on Snapchat, on Instagram, all of those places. Have any of you had to use naloxone on anyone? Not yet? Okay, but you all know what naloxone is and how to use it? No. Okay, so naloxone is a very, it's a life-saving medication that basically when someone has an opioid use disorder, or sorry, when an opioid overdose, they're basically not breathing. And so this is like a respiratory crisis. If there's no oxygen to like the brain and the body, that's when the organs start shutting down. So we need to figure out a way to kind of kick the opioid receptor off that portion of the brain that it's blocking. So naloxone goes into the brain, kicks that opioid off the receptor, and allows someone to breathe again. Naloxone is super easy to use. It looks like that, obviously. You put your index finger and your middle finger around the edges and your thumb at the plunger. You place it in someone's nose and you press it. Within like 90 seconds, if it's a true opioid overdose, they should start coming back. On Skid Row, we sometimes have to use like 8 or 9 to get people actually coming back just because they've been using so much fentanyl. But generally, if it's like an accidental overdose, 1 or 2 administrations of Narcan should help someone start breathing again. So really, really important. More importantly is, if you're using naloxone, please call 911 and get them to an emergency room as soon as possible so they can get like a full medical clearance to see if anything else is going on. It's available, all insurance will cover it. You can get it over the counter, but I think it's about like $45. So it's just a lot easier to get it from your insurance, or if you look on like the California Department of Public Health website, they also have like organizations that give naloxone in each of your counties. We also have fentanyl test strips. Has anyone had to use a fentanyl test strip or know how to use one? Yes, okay. So fentanyl test strips are really cheap. They're like 75 cents a pop online. You would just have to crush your substance and then dip the fentanyl test strip in there to see if fentanyl is in your substance. So again, if someone uses illicit substances, this is a really quick and easy way for them to help determine if fentanyl is in their system or in their substance, because then they're going to make a shift, hopefully, in their use. They're either going to use less of it, they're going to make sure they're not using alone, that they have naloxone around, or maybe they don't use it all that day. And then this is the overdose prevention hotline. So you can actually call them, this or the Brave app. You call them, you say where you are, they don't ask for your name or any other information. And they say like, if you stop responding in a few minutes after you use your substance, we will get emergency EMS there. So they will automatically do all of that for you in case you're using alone. And then we have lots of treatment options, but and then we also have psychosocial support. And then when I think about like treatment of substance use disorder, these are like the 4 things that I'm always thinking about: health, housing, community, and purpose. I always ask, like, do they have a safe place to rest their head at night? Is their physical health and mental health kind of like taken care of? What is their sense of community? Where do they belong? Who do they link up with? And then what are they doing all day? What is their sense of purpose? All of those are going to be really important kind of like pillars in trying to help someone reduce their substance use. Okay, we have 5 minutes. Going back to the case. Okay, so what would be important for your next steps for Mr. X? Which would you want to do? I mean, I think this is supposed to be a poll, and I don't know how to do that. Let's see. Oh, okay, so here. Okay, so you do Slido, and then you can check all that are appropriate. So you're going to ask, what's the frequency and amount of his use of possibly non-prescribed stimulants? When does he use them? Are there other substances he's using, particularly opioids, benzos, or other depressants? Where is he getting his supply? Does he have a history of overdoses? Who is his current support system? What were you hoping would happen when you drank or used substances? Okay, perfect. So you want to know who his support system is. Good, good, good. You want to know where he's getting his stuff. Perfect. Those are all, you're on the right track. Good. Okay, now when we do this, like these are the things that you've done. So how do you start this interview? What approach would you like to take? Because we also got a urine drug screen on him with his consent. How do we ask about his mental health? And then what harm reduction tools are you going to discuss with him? And so in the sake of time, you know, when you talk about it with him, he's revealing to you like he wants a social network. But he also says he wants to reduce his substance use. So maybe you're going to use some open-ended questions. Maybe you're going to ask like, how has using alcohol and stimulants been helpful for you? Has it resulted in any negative consequences? Maybe he shares that like he struggled with making connections with his peers when he's sober, but he's been able to do it. It's just more work. So you might say something like, you know, you've been able to forge these sustainable relationships even when you're not using substances. So you're going to affirm that he's been able to do something in the past and talk about how he could improve that in the future. You might reflect. So if he says, I've tried to quit drinking in meth so many times, but I always relapse, you might want to say then, you're really persistent. So even in the face of discouragement, you're still doing it. This must be really, really important to you. And then you're going to summarize kind of like everything that he's done. Okay, perfect. And then when we think about things in general, you're gonna think about referring him to mental health services, including medication and psychotherapy. You're gonna give him naloxone, fentanyl test strips. You're encouraging him not to use alone. Give him the phone number, the Brave app, and see him in a month. Okay, perfect. So in summary, that was really quick. Older people living with HIV have unique factors for using substances. You want to recognize those factors, create a very supportive environment that's non-judgmental, that doesn't use stigmatizing language, and then you're going to incorporate harm reduction and skills. Okay, perfect. Thank you so much.